Before turning it over to Adrienne Shapiro, throughout the day, I'm going to just thank our contributors and sponsors throughout the day, and our planning committee that worked really hard. In terms of some of our sponsors, we have Charles Drew University. We were here last year, and they did a phenomenal job working with us, and so we're here again in the community. Wells Fargo, it's always nice to have a good banking relationship with your banker, and so they came through, so thanks to Wells Fargo. Also, too, our job is to work collaboratively with the various organizations on behalf of sickle cell disease. So we're thankful to the Sickle Cell Council Advisory Committee in Northern California. So we have some Northern California folks here as well that have traveled down. Some of our contributors in terms of in-kind have been IMG Radio. Actually, Gary Johnson is providing the music for our network reception, so it's going to be fabulous. One of our members, Lynette Morgan, who works at St. Louis of France Catholic Church, she was phenomenal. She did all of the printing at her church in kind, so thank you for that. There's Panera Bread. There's Biology, Panda Express. The people who I really want to thank is Adrienne, Access Advocacy, and Nancy Renee. Thank you for your support. I'm Carolyn Rowley of Cayenne Wellness Center, the Executive Director, and again, I thank you very much for being here. Kiki Shepard of the KISS Foundation donated water, and again, throughout the day, I'll be just thanking our different in-kind donors. So right now, so that we can actually stay on time, I want to be able to turn it over to Adrienne Shapiro of Access Advocacy.
So some of you know me, some of you don't. I'm Adrienne Shapiro of Access Advocacy. We're a relatively new, formalized grassroots organization with a concentration on support and education for adults living with sickle cell. And we are so honored to be here and thankful to those of you who have shown up. Our community has gone for many years without support. And this is an exciting time for us. It's the first time in 50 years that sickle cell has been given funding, government funding, that it has been given pharma support, that our voices are being heard. It is a critical time for us because our adults are dying. I've said to many pediatric doctors, you've done a really good job of keeping our children alive. And to many ER doctors and hospitals, you've done a pretty poor job of keeping our adults alive. And so now we do have a voice. We have a voice, and we're like those when I was a kid, you know, I'm old. You get that little thing and you have the magnet underneath, and then all the little pieces start moving together and collecting together, and we have that movement now. And that is because people like you who show up to meetings, that is because people like you who make things happen, that is because people like you have conversations with bus drivers and pastors and people in cafeterias and things. So please continue this. This is vital. There is a universal cure. We all know that bone marrow transplants are the cure for sickle cell. It is the documented cure. If you have a familial identical match, it's actually covered by insurance and done for free. The problem is that due to our ancestry and our history, it is very difficult for us. In our backgrounds, we have come from people who left on their own accord, would have mixed and married, even through tribal warfare and conquering. It was slavery that gave us our African heritage. And, you know, we're genetically engineered, selected breeding, mixtures with Europeans and Spanish and Native Americans, and, you know, so 1 in 10 match. With that known, the community is working very hard on getting the gene therapy and stem cell therapy trials through. It's going to take a while. In the meantime, we have to keep people alive and healthy so that once that happens, we have the most amount of people who are cure-worthy. So next year's, I don't have it in front of me. Next year's seminar is going to be on gene therapy and stem cell work. It will be in the Fresno area, and you will hear more about that. So I'm going to bring in our first speaker. Trish Peterson. That's the panel, right? Yes. Come up. So you're first.
Good morning, everybody. Good morning. Happy Sickle Cell Month. No, it's fine. I'm actually going to speak on the moderator, so I'll call the panel up at this time. Trish Peterson, Dr. Hofstra, Dr. Johnson, Pat Quillen. Come on up. There's seats there for you. What we'll do, I'll announce the order that they'll come up and speak. And then this is going to be a very, very informative as far as Q&A session, where you'll have opportunity to ask some of the experts in the field some questions about what's going on, advancements. We're going to split it up into children and adult. And so we have representatives from the pediatric side and the adult side. And we're going to actually go ahead and present in the order that they're sitting. And so I'll introduce them, but I do have a few minutes just to say a few words. On September 18th, what day did I say? 18, which is a Sunday out in Loma Linda, we're going to have a sickle cell fair. Our third annual sickle cell fair is going to be a wonderful event. There'll be flyers out in front, so please do not forget to come out to Loma Linda and support us. It's a beautiful drive. Don't let the distance scare you. It's a beautiful drive out the 10 freeway. Come spend the day with us and then come on back. I'm very happy to announce that I'm actually local now. I was at Loma Linda for about 10 years, and I'm actually at Martin Luther King Community Hospital as a full-time hospitalist. So I'm very happy to be back locally here. I live locally also, and it's a very good feeling to be here and involved. And so I just want to thank the sickle cell community for actually welcoming me into the sickle cell community. It's something that you do out of passion. It's something that you do out of passion. There was a lot of pain that I had to go through in order to become part of the community. I had a lot of patients who had very bad outcomes in the hospital, and I reflected back on my medical school career, and I was like, we never really talk about sickle cell disease. I have maybe 1 or 2 patients, but as an attending physician in Loma Linda, I saw what was going on in the sickle cell community, I saw what was going on with sickle cell patients, and it was very difficult to reconcile that with the education that I had, and I had to scramble and learn. And some of the panelists that are sitting here welcomed me in and actually showed me the ropes, and so I just want to say thank you for that. And I'm very privileged to be the moderator for this morning session. I wrote something last night that I want to share with you before we get into it. Just bear with me, but sometimes when things are overwhelming to me, I like to write. And so I just want to share something I wrote in dedication to the sickle cell community. We hold these truths to be self-evident. All men, women are created equal. Created equal, created a sequel. What if the genetic mutation that causes the blood to twist into sickle gave rise to superpowers? Would I have to beg for funding? What if all men and women were not created equal? And this is in fact was the sequel, was the path to a deeper understanding of the empathy of man, a deeper understanding of how far we still had to go to love our fellow man and woman, a deeper understanding of what it meant to do no harm, but follow the sequel, do no harm and then do good. In 2016, my colleagues still ask, how long have you had sickle cell? The patient becomes the physician. The physician does not become the patient. Tell me of your pain on a scale of 1 to 10. How can pain stop at 10? What does it feel like to have your bones split in two? We split atoms and nuclear explosions occur. Whole cities disappear. Why can't we see their pain for what it is? The truth is self-evident. We were created equal, but this is the sequel. So I wrote that last night in dedication to some of the patients that I'm taking care of. And it can be very painful at times to see what our patients go through. And it's very difficult as a physician dealing with your colleagues sometimes to try to explain to the patient. One thing Pat Carolyn always emphasizes to me is listen to your patients. And that is not only your sickle cell patients, but all your patients. And so without further ado, just going to get to the panel. I'm the moderator, so I basically just timekeeper. That's all I am. And so we have Trish Peterson. She's going to come up and talk a little bit about the pediatric side. I just want to give her a shout out for starting the West Coast Sickle Cell Nurses Group. So thank you so much for taking the passion and the interest and the time to do that. And of course, as the other speakers come up, I'll briefly introduce them. But I'm going to turn it over to you at this time. And when you see me snatch the 5 minutes, you have 5 minutes.
All right. Thanks so much. Thanks so much for having me here today. You know, whenever we get invited to speak to people in the sickle cell community, normally it's nurses and physicians, and you know, and that's great, and we love to talk to them, but what's really humbling is speaking to the community itself, the people that are dealing with the disease and the other people that are helping take care of them. And so I had a similar experience when I first came out of school. I went to Mount St. Mary's and then to UCLA, and then I walked into Children's Hospital and I was ready to start my nursing career. And the first group of patients I took care of were patients with sickle cell disease. I don't even think I remember learning about sickle cell disease in nursing school. It must have been like a half-an-hour session, you know, somewhere in pediatrics. And so all I knew is that they had bad pain. I had no idea that there was different types of them, of the disease, and that each phenotype had different complications that I needed to be aware of. So I remember one day really clearly, and I had a patient with a pain crisis, and Dr. Coates actually came into the room, and I was like, okay, Dr. Coates, I have got this together. The patient is not in pain, itching is controlled, we are doing great, except her foot's a little bit numb, but I think she slept on it funny. And he just, like, his head started spinning. What do you mean, your foot's numb? Quick neuro exam, quick ICU call, quick exchange transfusion, the patient was having a stroke. I didn't know that. Ever since then, the hospital, you know, with other sickle cell nurses, we decided we needed to do more in terms of education. So we've been part of the the hematology, oncology, bone marrow transplant nurses. All the new nurses gets education on sickle cell disease. All the emergency room nurses gets education on sickle cell disease. Usually once or twice a year, we're talking to all the nurses about this disease. Because at our institution, you know, there's bone damage, so the ortho nurses need to know. Everybody needs to know about sickle cell. But that still wasn't enough. And then about 5 years ago, we had a phone call, Pat and myself and Debbie Harris, and some other nurses from around Los Angeles, and we're like, we're still not getting the word out. We need to do more. And that's when we developed the West Coast Sickle Cell Nurses Group. And we're having our 5th conference in a couple of weeks. And again, the emphasis is trying to get the word out about sickle cell disease. So anyway, I'm honored to be here today to talk about kind of where we have been with sickle cell disease and where we're going to be heading. I think I turned it off. Wow, that was a good first move, wasn't it? You can tell that I'm really good at these things. Oh, that one. Thanks. So we all know that sickle cell disease is a beta chain defect, and we know that it's caused by a substitution, and we know the chromosome, we know all of this. And that's really frustrating because as we know exactly where it is, we still don't have all the answers to this disease. We know that this is a qualitative anemia, and the hemoglobin is flawed, and it's just by this one amino acid substitution that seems to be causing such havoc on our patients. We know it's a disease of hemolysis, and as we're learning more about hemolysis, we're learning that that's a big problem. And lots of reasons can cause you to have sickle damage. So deoxygenation, dehydration, acidosis, even stress and infection. Now, I'm sure everybody who came to here today had some of this part of them. I mean, stress with the traffic, probably maybe you woke up late so you didn't get your water in, so you might be a little dehydrated. Temperature changes, although this room is really nice. You know, we have kids that are in college right now, and they're telling us that their college auditorium is too cold. So now they're getting pain crises the second week of school. Now they're in the hospital, they're falling behind. This is a disease that really, really disrupts life. But this is kind of the global perspective about sickle cell disease. And you're right, we do a great job in pediatrics, but the real story is that we're really failing sickle cell disease globally. About 240,000 kids are born annually in Africa, and about 80% don't survive. It's a travesty what's happening. We have about 80 to 100,000 people in the United States with sickle cell disease, probably about 7,000 in California. 97% of our kids survive to age 18. But the big story is not so much the pediatrics, it's what happens later. So this is just a picture looking at our survival in kids, and we're the top line up there. That's the Dallas cohort. This is from 2000 to 2007. The top purple line just shows that we're doing a really fantastic job, almost 97, 98% survival to age 18. Historically, infection was the major cause of mortality in sickle cell disease, and it was implicated in about 20 to 50% of deaths. So there was a large cohort that studied this over 30 years, and we know that the infection remains the leading cause of death in underdeveloped countries. And the reason is because of the reduced splenic function. Kids are prone to sepsis, especially with encapsulated infections. So it's really, really important that we get to the kids early on, teach the families what's going on, be aware, fevers, penicillin, antibiotics. There was a study called PROPS-1, which looked at in 1983, and it was seen that if you took daily penicillin, it decreased serious pneumococcal infection in kids under 3, and it showed an 84% reduction in infection in kids that were on penicillin. 84%, that's huge for just twice daily penicillin. That was probably one of the main reasons that we were able to get onto the newborn screen. Then they did another study that says, hey, if it's really good for the kids under 3, what about, everybody taking it forever? Well, then they just really showed that it wasn't really efficacious for kids to continue taking it after 5, as long as they were fully immunized and hadn't had really any serious infections. So at 5 years, we usually cut it off, and then, but we still monitor fevers. It doesn't mean that fevers after 5 is not an issue. It just means that they don't need to be on penicillin. This was the big one. In 1986, it was demonstrated that penicillin, again, greatly reduces the risk of serious blood infections, and that became the big incentive to get onto the newborn screen. It's been on the newborn screen since the 70s, but only California in 1990, and it identifies about 2,000 infants a year, and I believe about 25 to 30 kids in California a year. And at Children's Hospital, we're mandated to see the babies before 2 months of life. So once they get identified as having sickle cell disease, there's a rapid calls to families, to pediatricians, to the center, get these kids in so we can start talking to families. It's really through educating the families, because families have to be the biggest advocate for their kids. This just is talking to you, looking at where we've come. Again, what we've been doing, and the death rate in children has gone down, but really any death rate is unacceptable. So there still is work to be done, and it's not 100%. I would say that there was a time at Children's Hospital, it probably went about 9 years, when we hadn't lost a baby due to infection. And then, unfortunately, that streak was broken about a year and a half ago, secondary to an unimmunized kid that that was staying home with fevers. And then, and then so we go back and we hear about it, and we're like, this is a tragedy, it can't happen. We have immunizations, we have education. What happened here? So the infection is still, although very rare, it is something that is out there. We always have to be mindful. If anyone's ever seen pneumococcal sepsis, it's not something that you ever forget. So because of pneumococcal sepsis, there are now pneumococcal vaccines. And these are inactivated and killed vaccines. There was the Prevnar 7. When that came on the market, it had 7 different, what's the word? Subtypes, thank you. And that really helped decrease pneumococcal sepsis. And then the 13 came on, and it had additional subtypes. And so with the advent of the 2010 pneumococcal 13, pneumococcal sepsis again came down. It's really important, though, that all the kids get completely immunized. And so it's not just your baby series, but there's additional ones at 2 and at 5 that really help drive down the rates. The 13 has these fascinating serotypes. And based on the data from 2007, it would show that about 60% of the invasive pneumococcal diseases were caused by these additional strains, and that was the impetus to actually change the immunization vaccines from 7 to 13. Now, I know a lot of people get really concerned about all these vaccines for the kids, but it's just really important to see if there is research behind it that shows that these are preventing diseases. And a lot of us haven't seen these diseases, so then we think, well, why do we really need to do all these vaccines? But again, we're really trying to prevent this morbidity that happens with our patients. Influenza. How many of you guys got your flu shot last year? You guys are an informed group. Okay, excellent. You know, I can't tell you how many times people say, no, I don't want to get the flu, so I'm going to stay away from that flu shot. And I sit there and I gotta be honest with you that there was a moment in my life that I didn't give my kids the flu shot, and I remember one of our fellows saying, hey, do me a favor, call me when you're at home with your sick kids, and I'll just talk to you about the flu shot after they've had the flu. And I was like, oh, what am I thinking? Like, I really need to, you know, it's like talk the talk, walk the walk. Anyway, this is just the flu review from last year, and it just shows like there was a lot of A and B flu out there, and we know with patients with having any kind of pulmonary disease, any kind of lung problems like asthma, reactive airway, that flu can be very dangerous for them. 30% of our sickle cell patients, they have asthma. This is a really big deal. When flu season comes, it's a very frightening time for us at the hospital because we know that we've seen some kids get it and, you know, not too much happens to them. Some kids get it and they're in the ICU intubated for 10 days. You know, it can vary from child to child, so it's really important to get your flu shot. This is just talking about pneumonia and influenza mortality. This is ended just on August 27th, so this is the actual current stuff from the CDC, and it's just looking at these peaks here are your peak flu season dates. And so you see that this is like your end of like November, December into early spring, each peak. There's times when this really happens, and so you really need to educate your families, educate your patients that the flu shot is real and it can be protective. It's a trivalent this year. The way they come around, you know, they look to see which ones are the flu strains that are out there in the community, in the world, and they think which ones are coming our way, and that's how they kind of make it. It's kind of like a best guess. But even anyone having the flu shot, it's better than not having the flu shot. So yes, you could still get a bit of the flu if you have the flu shot, like not the same day. Like if you get the flu shot, then like maybe a month later, if you happen to get sick, you might just have like a lesser degree of flu. The recommendations is everyone 6 months and older should get the flu season every year. And I know this year the flu shot is actually a shot. They're not recommending any kind of intranasal spray. So again, can I get the flu from the flu shot? No. It's inactivated, and you could have just bad bloody luck by getting sick like right after you have the flu shot. But these things can happen, but it's not the flu that you're getting. And has anyone ever had flu? Okay, how does it feel?
It's horrible, especially when it turns into pneumonia.
Okay, right, it's different than a cold.
Yeah, no, and I've got a flu shot.
Exactly, I'm a believer, right? So, I mean, it's different, because a lot of people come in and say, oh, I had the flu last week, and I'm like, did you really? Tell me about your flu. And they'll say, oh, I got a really bad headache, and, I've had a fever. And I'm like, okay, but did you go to work? Oh, yeah, but I was miserable. No, honey, you did not have the flu. Okay, because if you had the flu, you would be on your back. Okay, you would be sick and you're out. Exactly. And so if you've ever had the flu, you know how bad it can get. And if you've ever seen it, you know how bad it can get. So again, get your flu shot. And again, the biggest difference is us here in the community, the sickle cell community. The most important factor is really just having a trusting relationship with your provider and being able to talk and discuss about this. So if you ever have concerns about immunizations or flu shots or any of this, or any treatment, really don't keep it a secret. You want to make sure you have that dialogue with your provider saying, hey, listen, I'm concerned about this. Let's talk about it, so that maybe they can say something that's going to waylay your fears. I always tell my parents, the patients that I take care of, if there's anything that's going on that you are stressed about, I want you to call me. Send me an email, whatever. I don't want you sitting at home worrying about something, because I could perhaps tell you something that might make you feel, oh, okay, we're going to be okay. Stressed out families, the parents, they're so worried about their kids. It's like you have to be able to help them. So we're always trying to have that open communication between us and our families. One of the most disastrous complications of sickle cell disease in the pediatric population is stroke. And we know that it can occur in about 10 to 15% of our kids. But 67% reoccur if untreated, so this is bad news. Kids are amazingly resilient, and a lot of them can recover, but some of them don't. And just because of that, you have to be incredibly cautious about taking care of your patients. So we do a lot of stroke talk. Yes, sir. Oh, 5 minutes, thank you. So, okay. Sorry about that. So, because of this, we do a lot of stroke education, and we make sure that our kids have TCDs. And we know that TCDs are the predictor for who's going to have a stroke. So we make sure that our kids have them every year after age 2. Most of the kids under age 2 don't stroke. And then kids that have strokes, we put them on chronic transfusions. If you just have a TCD that's elevated, we'll discuss what our options are. But right now, gold standard is chronic transfusions. Transfusions. Okay, we've come a long way. They're a real, they help out a lot of times with our patients with sickle cell disease, but it's not to be given just willy-nilly. A pain crisis and a transfusion is not going to perhaps help you too much. But for other indications such as splenic sequestration, severe anemia, acute chest and stroke, transfusion therapy is what we do. But transfusion therapy wasn't always as nice as it is now. If you can see down that first first transfusion in 1628, an English physician discovered that circulating blood, and after that he started thinking, hey, maybe we can do some blood transfusions here. So thank God it's not 1665. The first recorded transfusion occurred in England, and it kept dogs alive by transfusing dogs blood from one dog to another. Then they started to go a little bit farther. They started thinking about lambs to humans. They had a lot of transfusion reactions back then. Within 10 years, transfusing the blood of animals to humans became against the law. And then they started looking at other ways to do transfusions. And this is they did it from a man to his wife who was having postpartum hemorrhage. Again, lots of transfusion reactions. Then they started using transfusing milk, cows, goats, and humans. That didn't work out too well. Then they started looking at saline. Eventually, we perfected the art. Antigen-matched blood is the way to go. You want to make sure that your patients are RBC phenotype, meaning you have the most, you know exactly what type of blood fits them best, and transfuse as needed. There's a couple of, I don't have as much time, but there's a couple of studies out here that are looking at when we can actually stop transfusing patients that have had a stroke. There was a STOP trial that was looking at if they've had a stroke or if they've had high TCDs, can we eventually wean them down? That wasn't something that proved to be efficacious for our patients. Now they're looking at if you have an elevated TCD, transfusing them for a set amount of time and then potentially transitioning them to hydroxyurea, looking at as long as you don't have any kind of damage vessel narrowing on the MRI and the MRA. So there are some possibilities out there. Hydroxyurea is just a blessing. It really decreases hospitalizations and pain and hospital stays. Really, we're now able to start it as young as 9 months. I really am hopeful that our younger generation of sickle cell patients that have been on hydroxyurea since the get-go, that they'll have better outcomes for our adults. And just one last thing about our adults, and Dr. Hofstra will talk about pain. We've done a really great job to keeping our pediatric patients alive. And now the burden is pushed onto our young adults and our adolescents as they transition. Hopefully our adult group will probably speak on the difficulties with that population. Dr. Hofstra and I always get asked by our colleagues, why are you transitioning this patient out? Why are your patients still coming to our emergency room? And I just find it unconscionable to say, well, I can't just let them go out to the community if there's no one to receive them. So we continue to take care of our patients at the hospital. We're working with the transition program, and Annie is our nurse navigator for that program. We're trying to build community resources and partnerships with other physicians, such as Dr. Brathwaite. When we heard he was over in Loma Linda, we were like just doing somersaults around Children's Hospital. So thrilled to have another partner in this so that we can trust hand off our patients as they get older and we can no longer keep them at Children's. So with that, thank you.
Thank you so much. That was a lot of information we're going to take. Go ahead.
One thing.
Come on down. All right.
Just some of our patients, so we have blankets. I want to just interrupt for a quick moment. Those of you guys who need blankets, can you please raise your hand and thank you, and I'll bring them down. Because I know that in these kind of situations, it can get a little cold. Keep your hands raised and I'll bring down a blanket. Also know that the PowerPoints will be available on our website for a period of time for you to be able to capture the information. Keep your hands raised, thank you.
So just to recap this session, we're going to be doing from 9 to 11 this morning. We're going to do pediatric and adult. We're looking at pain, we're looking at the pathophysiology, and we're looking at NIH guidelines. And so we have pediatrics, and then we have our adult section. What I'm going to do is just ask one question. I see a hand raised here. I guess that's for Mikey. That's still for Mikey. Okay. I'm going to ask one question here, but then what I want you to do is, as the presentations are going on this morning for the 9 to 11 session, please write down your questions because there's going to be times to answer that after the presentation. So the quick question I have for Trish Peterson is, when you deal with non-sickle cell nurses, what I found in my hospital is that a lot of nurses are resistant to even learning about sickle cell. So it's not even, so they admit their ignorance about it, but then the next step is I'm not even interested in learning. So how do you engage the nursing staff that may not even be interested in learning some of the skills that are necessary?
Interesting. I was speaking at a conference earlier this year, and I was talking about pain and sickle cell disease, and I had about 200 emergency room nurses in front of me, and I was really talking to them about it, and I felt like we were all in it, and everybody seemed to be on the same wavelength. And then, the last question, I'm like, yes. So what do you do about drug addiction? And I'm like, did you hear anything I said? And so it's hard. And so you just go, okay, yeah, I see your concern, but let me educate you further. Let's talk about this, because yes, that was a interesting question after what I just discussed, but I felt like that maybe that might have been on somebody else's mind too. So then I was able to let's elaborate on this and let's talk about that addiction in this population is no more than addiction in any other population. And actually what I usually say, and the room goes silent, I say addiction in this population is no more than addiction in this room. And then and I'm also, so I'm not, so let the providers that know the patient and family well, let us worry about it. You take care of them when they come through your room. But I use some of their, maybe, you know how it goes. It's hard, but I think we've been really blessed at Children's Hospital because they saw a need to go and educate. And then again, with Pat and I, and the rest of the sickle cell group and all the other community groups, just really getting word out. And I really feel that in the last few years it's changed. It's not so much where you used to go in and 10 people would raise their hand and you knew you were losing the crowd. It feels like people are more engaged now. At least that's what I'm seeing. Is that what you're kind of seeing, Pat?
All right, so that was the one question. Then afterwards, again, we're going to have audience questions for everybody. At this time, I'm going to invite Dr. Hofstra up. And when I met him, this is the first time, just put your hands together, it's okay. It's all right. So Dr. Hofstra, when I met him this morning, basically said, I just want to talk to the people. So I'm going to let you talk to the people, Dr. Hofstra.
Do I need the microphone? Yes. Okay, I thought so. Darn it. I hate microphones because I forget I have them in my hand. I want to thank everybody for inviting me here, and especially at Charles Drew University. As everybody here knows who Charles Drew was. He actually was very important, and is very important to sickle cell disease. He was one of the physicians who transformed transfusion medicine and actually modernized transfusion medicine. As we know from when Trish talked about, transfusions are a very important part of what we do in sickle cell disease, and the advancements that we've made over time has been incredibly helpful in helping our young children, or my kids, I call them my kids, grow up to be adults, and I want them to stay healthy adults because there is going to be a cure in our lifetime for sickle cell disease, and that's my job. I hope is that the young men and young ladies that we take care of when they grow up will grow up into a different world than the adults have right now. I believe in conversation. I don't have any slides because I hate slides, and I get lost when I sit in a room full of slides. But I do want to know who I'm talking to. How many of you here have sickle cell? Excellent. So we have a lot of adults with sickle cell. How many of you are parents of a child with sickle cell? I know some of y'all are. Okay, or another parent, not just a parent, but a pride or healthcare. And how many of you here are activists? Excellent. So, excellent. I think we all should be activists. And when you're an activist, stories make a difference. Statistics are important, but stories to back them up. And I believe in narrative medicine, which is to tell a story to help people understand what happens. So I was asked, what is the politics of the past and the future of pain management in sickle cell disease? And I came from a Midwest university that had very little amount of sickle cell. I was trained in both internal medicine and pediatrics, so I've had some experience a long time ago, I'll tell you when, of managing young men and young ladies with sickle cell disease and grown-ups with sickle cell disease. When I started off, kids who got admitted to the hospital got intramuscular injections of pain medicines because they wanted them to want to leave. So we gave them pain management, we caused pain, to help them to pain. That to me was unconscionable, and that's one of many reasons why I decided to go into pediatric hematology. Was I thought these kids deserve better than that. I took care of an adult with sickle cell disease, only one in my entire training, and I was told he's clearly an addict, and all he wants is pain medicine. So, being the naive doctor that I was, I wrote him for the pain medicine I needed. 5 days later, he showed back up in our emergency room, and they said, "See, I told you he was an addict. He's coming back from our pain medicine, not medicine." And the problem we had, we gave medicine, we didn't give management. And what we need to do now is change how we approach that. So, how has pain management changed? When I started off in medicine, babies didn't have pain. They were just starting to recognize that babies had pain. Did you know that? In 1950, babies did not have pain at all. It was impossible. In 1978, oh, maybe they feel a little bit of pain. By the time I was in training, we were actually doing experiments to determine, do children feel pain? Do babies feel pain like grown-ups do? So we've come along that we actually recognize now that babies feel pain like real human beings do. I tell stories about sickle cell disease because, and pain, from the perspective of somebody who doesn't have sickle cell. But how many of you have broken a bone? How many of you with sickle cell disease have broken a bone? Which hurt more, your sickle cell pain or breaking a bone? Crisis, and actually, that to me should make sense because I taken care of this kid who was 3 years old, and the family didn't bring the kid to the hospital until 2 days after a broken bone happened because she wasn't nearly as upset as she was when she had sickle cell pain. Intellectually, I understood that. I had never broken a bone, but I said, "Wow, that's pretty intense." Anybody heard her smash her finger in a car? I can tell you the exact time and day that it happened. It happened on Friday evening at 7:15 at Oak Park when I was in the 10th grade. That's how bad that pain was. So I had a teenager come up that one day and she was bandaged. I said, "Brandon, why is your finger bandaged?" He looks at his finger, he looks at me, looks at his finger, and he says, "Well, Dr. Hofstra, I smashed my finger in a car." I said, "How does that feel compared to your sickle cell disease?" So now, the worst physical pain I've ever felt in my life, I'm going to have a